Assalamu alaikum everyone and good morning. And today we have got Dr. Abdul Rafi from Sakkar, and he will be presenting on the topic that is TURBT. Please.
Thank you, Dr. Yasir. Good morning, everyone. In continuation with our series on bladder cancer, today we will talk, and more specifically on the non-muscle bladder cancers, we will be talking about TURBT, diagnosing, staging, and treatment. This session is, of course, you already know, is moderated by Dr. Yasir. So we will be talking a little on how to diagnose bladder cancer, what is TURBT, the surgical techniques, the procedures, the instruments that we use in this resection, what are some of the challenges that we face, and what are the complications that we encounter in during TURBT. So this is a little recap on the last week's presentation, what is bladder cancer, and some of the epidemiological facts on bladder cancer. So it's a common urological malignancy. It is evident from the fact that the number of patients we are seeing in every Tuesday and Thursday OPDs, this number is very large. This speaks volumes for itself. The majority neoplasm is epithelial in origin. It's accounts for 90% of all the bladder cancers. But this fact is not global. There is a certain geographical distribution that we have seen in Africa and other parts of the world. Other variants of bladder cancers are more common than epithelial cancers. Of all the bladder cancers, 70% of all are in the non-muscle invasive bladder stage. Men are 3 to 4 times more likely to develop bladder cancer as compared to women. Smoking is recognized as a major risk factor as well as occupational exposure to aromatic amines. And the non-muscle bladder cancers carry a certain risk of recurrence and progression, which becomes significant when we talk about treatment options and the tumor characteristics of the tumor. So just a little word on the relevant anatomy. Bladder is a hollow organ which stores the urine and evacuates in a socially acceptable condition. It is a layered structure from inside out. You may see a urothelium followed by lamina propria, and then there is muscularis layer. Outside is serosa, and then we surround the bladder with perivesical fat. This becomes significant because when we are going to talk about the TNM staging, which is actually the depth of the tumor invasion, it is upon the layer in which the bladder has invaded, the depth of layer in which the bladder is invaded. The TIS is the flat tumors, and followed by TA, which are the papillary lesions. T1 is bladder, the growth is invaded into the lamina propria. So we are grossly dividing bladder cancers into two groups, the non-muscle invasive group and the muscle invasive groups. So this is here, the line is drawn for the non-muscle invasive cancers. And beyond this, this is the muscle invasive group, the T2, in which muscularis has invaded. T3A, there is serosal microscopic, T3B, a macroscopic serosal breach, and T4, the disease is not organ confined anymore. The pathological grades of the tumor is the architect of the tumor, how closely it resembles to the parent organ, and how different it is. In 1973, the WHO grossly divided the tumors into G1, G2, and G3, but it was causing some confusion in labeling the disease, and hence the risks of recurrence and progressions were not clearly defined by it. So in 2004 and 2022, they redefined it, and the guidelines suggest that we should be using both of these grading systems in order to define the cancer. So patient typically presents with painless hematuria. Other symptoms include painful micturition, and pain and irritating voiding symptoms. But painless hematuria is the main presenting symptoms. When we are suspecting a patient is suffering from bladder cancer, the workup typically includes complete history, physical examination. Although in non-muscle invasive, it may be of little value, but physical examination always helps us in defining the disease characteristics. Urine cytology is always been discussed when we are discussing bladder cancers, but due to low sensitivity and specificity of these tests, uh, they have a questionable sort of situation when diagnosing. However, they do have certain significance in surveillance of bladder cancers. We have device other urinary biomarkers such as Eurovision, which incorporates the technology of fluorescence in situ hybridization. This augments the urine cytology in detecting bladder cancer. We can always use imaging. Ultrasound is just an augment to the physical examination, and it can we can visualize bladder growths if they are projecting into the bladder. However, in muscle invasive group, they are of little significance. CT urogram, CT chest, abdomen, pelvis can give us the clinical stage of the nodal involvement and metastatic involvement. Similarly, MRI can also tell us about the muscle invasion. However, the gold standard always has always been the cystoscopic examination of the bladder, and to go into the bladder and see the growth for yourself. In the last presentation, Dr. Hamza talked about cystoscopy and various other uh, modern techniques that they are using, such as blue light and narrow bed, in order to diagnose or rather not miss any bladder growth. And finally, the topic of today's presentation, transurethral resection of the bladder, which is the initial treatment as well as have a is the main cornerstone diagnostic pathological diagnostic tool for our bladder cancers. So TURBT is the complete transurethral resection of all the visible growth with adequate depth, which should include muscularis propria, and we should be able to properly stage the disease. It is the initial treatment for bladder cancers. It has a value of being diagnostic as well as therapeutic, and the quality of the TURBT that we are doing is of paramount importance, because it is how it will define later how the disease may progress. Are we able to? Did we understate the disease? Did we overstate the disease? And what is the treatment will ensue from the first TURBT that we are going to do. So a brief word from the pages of the history. Cystoscopy has evolved tremendously from the candlelight that was invented back in 80s, and now we have very advanced techniques in detecting bladder cancers. So this gentleman here is Edwin Beer. Is a Mount Sinai urologist who has been accredited as the first person to use electrosurgery back in the early 90s. And the somewhat modern form of the resectoscope that we see is being credited to John and Sweeney. They invented it in 1960s. What is a successful TRBT? So a TRBT should be able to define uh, these following things of a bladder. So it should identify factors that are going to assign the risks of the disease. What are the number of tumors? What was the size of the tumor? What is the architecture? What is the grade? What is the location? Whether or not there was CIC? Is this a recurrent disease or is it a primary tumor? Bimanual examination under anesthesia is done at the start of resection and at the end of the resection, and it gives the idea of fixation of growth with the surrounding structure, and which in turn later tells about the invasion of growth into surrounding structure. We should be able to sign the clinical stage and the adequacy of resection. Ideally, TURBT, in TURBT, we should achieve complete visual resection of the growth. However, this is not always possible in every growth. Sometimes the growths are multiple and they're large in number and it's a very big growth. Visualization of muscle at the base, and we must always have the base of the growth, and the muscle must be included into the biopsy. And we should also be able to not miss if there was any complication, if there was a perforation, so that shouldn't be missed at during the TURBT. So typical pre-op, in the initial consultation, we have asked about the history. We have taken the personal history because this is very relevant. What sort of work he is doing, and is he taking? Is he a smoker? Because we know that smoking is a risk factor. Medication history, taking anticoagulants and NSAIDs and aspirins, they are always associated with hematuria and later on clot retention and morbidity for the patient. So we should have a note of what anticoagulant therapy this patient is on. Prior surgeries, specifically in genitourinary tract, whether this is the first tumor or it is the resected tumor, it is a second resection. If it is the second resection, then what was the grade and the stage, and what sort of treatment that he took for the initial stage. A proper GA fitness and a cardiac fitness. Typically, this stage, the tumor is presenting in the fourth decade, and with the majority of patients in the seventh decade. So they are patients that may require a good general anesthesia assessment and cardiac and pulmonary status if needed. We have already talked about the diagnostic stuff. We should always have them with us in the OR before the patient is being sent for surgery. We should have a proper image of where to expect the growth if it's lateral wall, because it is going to help us in giving anesthesia, whether or not we should give a muscle relaxant or not. We typically here at SIUT perform a urine culture and give antibiotic to the patient before starting the surgery. Counseling always is important. The patient expect that they have underwent a very good laser surgery and then the disease is gone. But this is a disease which is hallmarked by recurrences and progression. If we are losing our patient in if the patient is lost to follow up, then few months or even years later he will present in a very advanced stage, because we were unable to define to the patient that what sort of a disease he has, the risk of recurrence that it has with it, and the risk of progression that it has with it. And finally, before giving anesthesia, we should have a clearance from all the medical teams that we have. So this is a typical trolley that we see. I have this image from the internet. I should have used our own, but this is what a typical trolley of TURBT, what we see. These are the draping sets, irrigation channel, and then these are the parts of resectoscope, the working element with a fitted electrode as well as other electrodes, which includes a loop and a ball. 30-degree lens is typically used for resection because it gives us the vision of the loop that it's cutting, the outer sheath and the inner sheath. And on the the left half of the screen, you see the aliquot evacuator, which evacuates the chips, and the beside it, it's a Tommy syringe. It's also serves the same purpose. And in the leftmost part of the screen, these are the cables that are the camera and the cable setup that you typically see in the OR. The procedure is done in the lithotomy position after anesthesia is induced. Uh, anes- General anesthesia as well as spinal anesthesia both can be given, but general anesthesia becomes of relative importance when we are expecting a growth to be present in the lateral wall, because obturator nerve passes from the lateral wall of the bladder, and a resection that is being done will stimulate the obturator nerve. This obturator nerve in turn stimulate the adductor part of our legs, more specifically adductor longus, and will cause an abductor nerve reflex, which is one of a major uh, cause of perforation. The reflex in itself does not cause anything. It causes the legs to abduct, which will hit the surgeon, and surgeon with the instrument inside the bladder will end up perforating the patient's bladder. Bimanual examination, as already discussed, after the anesthesia is given, bimanual examination of bladder is done, and then it is repeated again at the end of the resection. It helps us to define about the fixation of the bladder or of the growth with the surrounding structures, and can give us a clinical sort of assessment of the disease. Before TURBT, pan cystoscopy is always advisable to give us the whole picture of the bladder. It should be done with a 30-degree and a 70-degree lens. Every part of bladder should be examined, including dome and the interior wall, prostatic urethra in itself, bladder, and the bladder neck. Nothing should be missed. After we have a complete map of the bladder where the growths are, we start our resection of the growth, typically by 30-degree lens, and uh, it's done with the monopolar resection, but bipolar sections are also done. Continuous irrigation should be enough to only minimally fill, to only be done enough so the bladder is only visible. Over distended bladder will, in an over distended bladder, there will be high risks of perforation. So the outflow channel should be set as the bladder is minimally filled with optimal visualization of all the growth that is present. So the resection is carried out by either piecemeal or an en bloc resection, and we'll be talking about both of these in subsequent slides. What are the advantages of piecemeal and what are the disadvantages with a whisk? So tumor is lifted from its edge to visualize the base and avoid perforation of the bladder. Additional biopsies should be taken from the mucosa, or more specifically from the base of the growth, in order to not miss the muscularis layer, and because missing muscularis layer would later on having an understage disease, we would have to go for a second look, and so the followed by chip evacuation. It is typically done with the aliquot evacuator, and at the end of the day, we should always confirm the hemostasis of the bladder. If there is one, it is fulgurated by a rolly ball, and by the end of visual, hemostasis should be confirmed. Irrigation fluid for monopolar resection, NS cannot be used because the ions in the normal saline, chloride, and sodium, they act as conductor, and they would be conducting electricity throughout the bladder, hence causing the electrical and thermal injuries. So RO water and glycine is used. Glycine is typically expensive, so RO water is rather cheap and a safe option when doing a monopolar resection. However, in bipolar resection, we have the liberty of using normal saline. piecemeal versus en bloc. In piecemeal, we are cutting the growth in parts from the but the piecemeal section is the fraction inside of the growth. It gives us, although it may give us the good information about the layers for vertical and horizontal, but what it does is it disrupts the architectural integrity of the disease. So we are not seeing the tumor as a whole, rather than we are seeing the tumor in pieces. And since the pieces are small and there are electrical burns from the loop that we are using, so we may somehow be disturbing or disrupting the architect of the growth of the patient, of the tumor. It is always advisable to take labeled biopsies and send them in labeled segments in order to help our pathologists to know what part of biopsy is being taken. Uh, it is against the oncological principle of taking the specimen out as a whole, but somehow when the growth is large, this is the only option that we have uh, left. Versus the unblocked resection, in which we remove the bladder tumor as a whole. The specimen's integrity remains intact, and we can take out the whole growth along with its space, and it gives us a rather more complete and a rather more proper tissue diagnosis. It provides a high quality resection and with the presence of the detrusor muscle in almost all of the cases when done in a correct way. Monopolar and bipolar. The traditional one is the monopolar. The principle is when the it converts the electricity into the thermal energy, it converts the electrical energy into the thermal energy, and this thermal energy heats the water. More specifically, the water is in our cell. When they are come into contact with heat, they vaporize and then they give the desired effect that we want. Whether we want cutting or we want coagulation of the disease. Uh, and the bipolar resection works on the principle of uh, plasma kinetic arch. The two loops are very close to each other, hence the energy does not flow through whole of the patient till the pad is present, and the electricity is limited between the two loops of the bipolar. Theoretically, it has the advantage of that the obturator nerve reflex is close to zero, but it is not never close to zero. There is a low risk of nerve stimulation in bipolar. Compared to monopolar section, bipolar section has reduced the complications such as bladder perforation, and it provides a good specimen. Uh, it is increasingly becoming popular, and it is easy to use. The advantages of bipolar section is that we can use normal saline and rather than water and glycerine, and hence lower chance of TUR syndrome, less cautery effect, and lower chance of obturator nerve stimulation. So when we see compare the both of these resection, there is less shorter of operative time, less blood loss, shorter catheterization time, decrease obturator nerve stimulation, uh, decrease in the incidence of bladder perforation compared to the traditional monopolar procedure. And there is the decreased rate of review. This is the results of the meta-analysis that compared the two modalities, section modalities. A second TURBT is typically done 6 weeks after the initial TURBT, when the section is either incomplete or there is a high grade T1 disease, and we were unable to take the biopsies, so we go in and take we do a Re-TURBT, typically done 6 weeks after the initial one. It provides more tissue for diagnosis and reduce the likelihood of understaging a T1 disease. uh, uh, this is a little checklist that we should go when we are doing TURBT, during TURBT and after the TURBT. Examination should include urethra shouldn't be missed, prostate shouldn't be missed. We should go and see for growth in and around ureteric orifice. If there are diverticuli, uh, we should go in and see for any growths in the diverticuli. Tumor location, number, size, appearance should be documented because they become very significant when we are associating or when we are assigning the risk factors of the disease, whether it's a high risk disease or a low risk disease. Uh, White light cystoscopies or photodynamics or narrowband imaging, they always help us in uh, visualizing the tumor better because white light sometimes is not sufficient to properly entail all the growths. So these techniques have always been helpful. Urine cytology, bladder wall cytology. If there is no visual growth and the patient is presenting with symptoms and there is a suspected high grade cytology in a urine, so we should suspect urothelial growth elsewhere, such as upper tract TCC, and it should warrant an a proper investigation and imaging of the upper tract, whether or not we are missing any upper tract TCC. We have already talked about the resection, the standard or the piecemeal, the unblock. When a growth is very small and friable, we can take the cold cup biopsies, and when the growth is of a low grade and a small growth, and roller ball cautery is also done. Depth and completeness of section has to be ensured. Visualization of blood of the reducer muscle in the place is a marker that we have taken the muscle in the section, and if the biopsy confirms, then it is a good adequate TURBT prostatic urethral biopsy. If required, should be taken. If any additional, suppose we are suspecting any perforation and done, we should be able to uh, uh, catch those complications. If required, a retrograde study can be done. Blood loss is estimated, and if required, intravesical chemotherapy either post-op or in the adjuvant setting can be given. Post-TURBT, the surgeon should review the pathological stage of the disease, and then we are better able to give or discuss with the patient the management plan as to how we are going to progress through this difficult journey that this patient is on. Some of the challenges that we face in TURBT is when there is a growth in the dome, and then there is a growth in on the interior wall of the bladder. TURBT in diverticuli is a difficult subject, and what to do when the growths are in the ureteric orifices. So tumor within first diverticular tumors. Tumor within the diverticulum are considered to be difficult. Sometimes the neck of the diverticuli are not very big in order for us to go inside with the instrument, and we know that they lack muscular esmagosa, and if there is a large risk, there's a risk of perforation. When we are doing the endoscopic resection of the diverticular growth, if there's a large growth, we can always consider the option of diverticulectomy, partial versus or radical cystectomy if needed, to deal with a large high grade diverticular masses. Uh, if the tumor is involving the anterior wall and the dome, these tumors are difficult for our traditional instruments to reach there, and by digital manipulation, either by pressing the suprapubic area for the dome to come down and resect. Similarly, for the interior wall, we can use digital manipulation, and by controlling the amount of fluid that is or the irrigation into the bladder by minimally filling it, we can also reach towards the growth. Patients all sometimes have growths that are very near to the ureteric orifice, which are causing obstruction to the kidneys. When cutting, pure cutting should be used in order for minimal charring or scarring of these tissue, because later on they would end up uh, obstructing our ureteric orifice and causing kidneys to go into the obstruction. So typically, pure current should be used when we are cutting these tumor. Resection of if there is an intramural ureter, it should be complete to in order to completely eradicate the tumor, and there 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 are always a theoretical risk of reflux of these malignant cells. What are some of the complications that we encounter uh, while doing transurethral resection? So, iatrogenic injuries to the bladder. We have already talked about the obturator nerve reflex, in which the nerve is stimulated and the adductor longus, more specifically, is stimulated. That would end up with our instrument perforating the walls of the bladder. These perforations can either be extraperitoneal and intraperitoneal, and we have already in the previous lectures discussed the management options for these perforations. So care should be taken with the instrumentation, specifically in the urethra, and we don't want to end up having a patient with a bladder cancer and a urethral stricture patient. Care should be taken while the growth is being resected around the ureter. Patient may report irritative symptoms the uh, after the installation of Foley's catheter, and they may report these. There is always a theoretical risk of TUR syndrome with this section. The risks of complication, urosepsis, fever, and other complications of infections are always in the post-op period, and hematuria is also one of the major complications, which may be transient and self-limiting at times, and sometimes it is not sufficient, not self-limiting, and may require endoscopic evacuation of the clots and then hemostasis, also requiring transfusions for the patient. So we have already talked about obturator nerve. Here is a video that I found on the internet, in which the surgeon explains his horrors while performing a loop section of the bladder, and this whole jerk movement end up with a perforation in the bladder, and we can identify that now there is a big perforation in the bladder due to this nerve reflex. Uh, Thank you very much.